At the emergency department, 65-year-old Christian came in complaining of headaches, vision problems, and memory loss. These symptoms have gradually progressed over the past couple of weeks. On examination, there's slurred speech, and his gait is unsteady. He has a history of chronic alcohol abuse. Head CT shows a crescent-shaped hyperdense mass that crosses the suture lines. Later that day, 33-year-old Max is brought in after a fight. They reported being knocked unconscious, but regained consciousness after an unknown period of time. Head CT is ordered and shows a lens-shaped hyperdense mass that doesn't cross the suture lines. Max was very agitated and said they felt fine. They then left the hospital against medical advice. Later that day, Max lost consciousness again and died at home. Okay, so Christian has and Max had some form of traumatic brain injury. When an external force damages the head resulting in temporary or permanent brain dysfunction, we call it a traumatic brain injury, or TBI. Now, as a direct result of the external force, TBIs can cause extraaxial and intraaxial injuries. Extraaxial injuries are within the skull but don't involve the brain parenchyma. The most high-yield ones are epidural and subdural hematomas, as well as a subarachnoid hemorrhage. Intraaxial injuries, on the other hand, do involve the brain parenchyma, and the most high-yield one for your exams is diffuse axonal injury. Now, sometimes trauma initiates a series of molecular events along with a primary brain injury, which can persist for hours or even days. These are referred to as secondary brain injury and eventually can result in increased intracranial pressure, which in turn has numerous consequences. And for the exams, the most important is brain herniation. Okay, now let's take a closer look at these different types of traumatic brain injury, starting with the extraaxial injuries. Epidural hematomas occur when blood collects in the space between the dura mater, which is the outer layer of the meninges, and the inner aspect of the skull periosteum. This happens when a linear fracture occurs at the region where the frontal, parietal, temporal, and sphenoid bones join together. This region is called the pterion, and it's the thinnest part of the lateral wall of the skull. For the test, remember that a fracture at the pterion can tear open the middle meningeal artery, a branch of the maxillary artery, causing profuse bleeding. The most important concept to keep in mind is that individuals with epidural hematoma classically have a period of loss of consciousness and then a lucid interval. During this time, the individual regains consciousness and feels fine, but a lucid interval isn't always seen. Symptoms are due to the buildup of blood trapped between the dura mater and skull, which increases intracranial pressure. Now, what makes epidural hematomas so dangerous is that the dura mater is attached tightly to the sutures of the skull, so the blood can't cross these sutures and is trapped with nowhere to go. This means the intracranial pressure can increase rapidly. The individual can develop headaches, nausea, vomiting, and focal neurological symptoms like weakness, numbness, vision, and auditory problems. As the hematoma grows rapidly, it can cause a life-threatening brain herniation, resulting in the loss of consciousness, coma, and death. A brain CT is diagnostic and classically shows a convex, lens-shaped, hyperdense collection of blood that does not cross the suture lines of the skull. There can also be evidence of scalp hematoma due to the head trauma. In addition to the bleeding, there can be surrounding cerebral edema, and if the edema is significant, it can cause a shift of the midline to the contralateral side. This signifies an impending brain herniation, most commonly a transtentorial herniation. Epidural hematomas are an emergency, and neurosurgical intervention is often necessary. All right, moving